Well, I should now let me know if because I now can't see you guys. So give me a shout if you can't see the screen
Yeah,
or hear
I
me.
can see it full screen. That's
Perfect.
great.
Good. So yes, as I say, thanks to John and Linda and Joan, obviously, for asking me. So we're going to have a talk about autoimmune liver disease, which most of you on the call will know is my kind of particular area of specialty. So a few declarations from some of the companies that are big in this area of work. So we'll start by thinking about primary biliary cholangitis. Now, many of you on the call will be aware of PBC, and really there are two main goals of therapy here. So one of the autoimmune liver diseases affecting the small bile ducts in the liver, and we want to reduce the risk to people's lives and the need for liver transplantation. And we want to do that by modifying the disease, so reducing risk. But also equally of importance, we want to improve people's quality of life. Some people with PBC do suffer significant symptoms, particularly itch, fatigue, and some of the brain fog or cognitive symptoms, which can be very limiting for people and equally as important as us being able to improve blood tests. So just a brief overview of PBC. So all of the autoimmune liver diseases are rare. PBC is actually the commonest, so it's affecting about 35 per 100,000 in the population. And it's a very female predominant disease, so over 90% of patients are female. An average age at the time of diagnosis is about 65 years. I think one of the commonest questions I get asked is, why has this happened? And it's important to say that none of the autoimmune liver diseases are linked to lifestyle risk factors. There is no evidence that alcohol, for example, triggers autoimmune liver disease. There is a genetic component. So families, we often see one person has PBC, one person has an underactive thyroid, but they are not directly inherited diseases. So you can't pass it from one generation to another. And some of you will have taken part in my PhD work, and that was looking at the influence the environment has on autoimmune liver disease. So increasingly, we think it's probably a combination of genetics and the environment. And some people just have a quite overactive immune system. So more than half of people also have another autoimmune problem, as I say, for example, hypothyroidism. PBC is actually the easiest of the autoimmune liver diseases to diagnose. So raised alkaline phosphatase, so this is one of the classic liver blood tests, and some positive antibodies, so these are proteins produced by the immune system, particularly in PBC, the anti-mitochondrial antibody. That combination of factors is over 95% accurate at diagnosing PBC. And you'll see I've put liver biopsy in brackets at the bottom because actually we hardly biopsy anybody anymore because we have such accurate blood tests. And one of the things I wanted to touch on, some of you may be aware of the targets that we use in terms of alkaline phosphatase. We think about risk in PBC and trying to assess who needs better treatments, newer treatments, more aggressive treatment. And there are lots of different scoring systems. Some of you may have heard of things like the POISE criteria, for example. There are lots of them and it all gets a bit complicated. But more recently, we have information. So this data is taken from the Global PBC Study Group, which is, you might guess, is an international study. And it's demonstrating that actually probably what we should be targeting is normal liver blood tests, that any ongoing level of abnormality, we should be trying to get it even further improved. And by normalizing people's blood tests, alkaline phosphatase and bilirubin, we actually improve people's long-term outcomes. And first-line treatment, ursodeoxycholic acid, this medication will be familiar to many of you. Actually, it's a really good drug. It has to be used in the proper dose, though. So this graph on the right here, so the bottom line, which you can see dropping off quite quickly, is people who weren't treated with ursodeoxycholic acid. And then the top light blue line is people who were given a proper dose. And this graph means that people given a proper dose of urso do better and avoid transplant more effectively. And the proper dose is weight-based, so 13 to 15 milligrams per kilogram. That can just be taken all in one go at night. It doesn't have to be split. And as soon as we diagnose somebody with PBC, we want to get them on treatment as soon as we can. And whilst ursodeoxycholic acid is a very good drug, there are a proportion of people who don't have a complete response to it. And we now have two options for medications that we can add in for those patients. So firstly, obeticholic acid, or Ocaliva is the trade name. So this has been licensed now on the NHS since about 2018. And it works by protecting the cells within your liver from the toxic bile acids that damage them. It also helps bile to flow out of the liver. One of the problems we see, and really the kind of only major side effect, is ironically itch, given that we've said itch is one of the symptoms we see in PBC. But we can almost always control that itch with other medications. It's quite strictly licensed, and you have to have been on that proper dose of urso for at least a year or not able to tolerate urso to be eligible for obeticholic acid. And we also have bezafibrate. I use this a lot actually in the Newcastle service. Now, it isn't licensed for PBC in its own right, but it's used a lot for lipids, so the management of cholesterol. And again, it's working by helping the bile flow out. And in contrast to obeticholic acid, actually, bezafibrate is good for itch. So we sometimes get kind of two for the price of one, if you like. We make your blood test better and improve itch. It's just a once-a-day tablet. It does carry small risks of an injury to the liver and the kidneys, so we keep a close eye and monitor so that if we have a problem, we can stop it straight away. And we now have studies, so these medications have been looked at in fairly big cohorts of patients now, and both obeticholic acid and bezafibrate have been shown to improve long-term outcome in terms of how long people live and avoiding transplantation. And this is just a mention of a study that we've opened just very recently within the last month or so in Newcastle. So this is the OPERA trial. So we've talked about ursodeoxycholic acid, we've talked about obeticholic acid, but actually we also know that we can recognise people who have got fairly high risk PBC right at the point when they're diagnosed. We shouldn't have to wait to give those high risk people proper treatment. And actually the current way we have to use obeticholic acid is waiting at least a year. And I think in the clinical community, we don't really think that's going to be appropriate. And OPERA is looking at whether actually, if we think you have high risk disease, we should start straight away with a combination of ursodeoxycholic acid and obeticholic acid. So we've just started recruiting. So if anybody with PBC would be interested, now this, remember, is a new diagnosis, so you can't have had PBC for very long, so it just really needs to be within the last few months. I think this could be a really important trial and potentially will change the way we approach treatment of PBC. And I mentioned at the beginning, so we can make your blood test better. So urso, obeticholic acid, fibrates are all well and good, but what about quality of life? Some people will, the idea of these symptoms will resonate with them in terms of the fatigue and brain fog, and then the sensation of kind of wading through cotton wool. Pruritus, just a posh word for itch, and also associated symptoms with dry eyes and dry mouth. It's really difficult. You can't isolate each of those symptoms individually, I don't think. I think that probably oversimplifies things, but they all interact. Itch affects sleep, sleep affects your social and emotional state, whether you can work, your activities of daily living, all of those things interact. And we actually know that the quality of life reduction in patients with PBC is even greater in younger patients. And this is an interesting study published just a couple of years ago. For people with overwhelming fatigue, I think the very understandable need to feel that they can do less. But actually the evidence is that we should be quite the opposite, trying to really encourage exercise. So graded exercise programs can be incredibly valuable. And this study was looking at a home-based exercise intervention, so not going out to the local gym, etc., or going out on a bike, but something relatively simple, can be bespoke to the individual, so it can be tailored depending on what an individual can do, actually improves fatigue. We know that in patients with PBC who have fatigue, they often they describe the feeling of their batteries running down, and actually people are often better in the morning. So doing more in the morning before they get very fatigued later on in the day can be very positive. And we're quite good with blood tests, but we really struggle with treating fatigue and that cognitive function side of things. And again, just to mention the OAKS trial. So these are actively recruiting, and we would very much like people to take part if they would want to, or get in contact with us for more details. So obeticholic acid, we've explained that actually we use this for people with high risk disease, and their risk is being based on their blood tests. But actually, there's data published from the Newcastle group suggesting that if you give obeticholic acid, it can also improve symptoms. So this is the aspect we're trying to look at. This trial is for anybody with PBC in terms of time. So you can be a new diagnosis or have had PBC for years. And it's a placebo-controlled trial. So all that means is that 50% of people in the trial get the active drug, so they get obeticholic acid, and the other 50% get a dummy drug, if you like. So neither the patient nor the doctor nor the research team know what medication you're receiving. And that's so that we can be unbiased in terms of understanding the effect of obeticholic acid. The trial only lasts about 6 months. And just a note to say that patients on fibrates can't take part because it would affect the trial results. And if we think about itch, so patients often come and see me in clinic, and one of our kind of specialist areas is trying to manage itch for people. And if you ask somebody with liver disease to describe their itch, they give an absolutely classic description a lot of the time. So worse at night, worse if they're hot, disturbs their sleep. An itch sounds like a pretty minor thing, but actually having looked after people with severe itch, it absolutely destroys some people's lives if it's severe. You obviously need to make sure that there's no blockage from the bile flow from the liver, so you need to do some scans to make sure. And remembering that being low on iron can also make itch worse, so particularly in young menstruating females, I would always check for that. And we have lots of medications for itch, and it's relatively unusual, thankfully, that we can't control itch with medications. But for the small number who we really can't get on top of things, we do actually undertake liver transplant for itch. And it's one of the very rewarding parts of this job. People we transplant for itch, you literally go and see them when they've just come around from their anaesthetic and their itch has gone away for the first time in years. And they never quite believe me that it's going to have disappeared, but it does. It's really quite a spectacular thing to see. And this is my kind of ladder, if you like, of how we approach treatment for itch. If you ask lots of doctors, they'll give you a slight variation on a theme. But I would start with bile salt sequestrant. So this is Questran or colesevelam that some of you will have come across. Those medications are very safe, so we always start with those. We then move on to rifampicin. So actually, slightly bizarrely, it's an antibiotic for tuberculosis, but it's a very good tablet for itch in some people. And you can see on the left there, I've kind of slotted in bezafibrate. Increasingly, we're using bezafibrate, as I say, for this kind of 2 for the price of 1 blood test and itch improvement. And I think it probably will slot in at about the same level as rifampicin. And then we get into some other medications. So gabapentin. So this is actually usually a painkiller used for nerve pain. Naltrexone, which is a kind of a morphine antagonist, which can be very effective, but can have quite a lot of side effects. Sertraline, again, some of you may have heard of this. So sertraline is actually an antidepressant, but it can work extremely effectively for itch. And I think sometimes, particularly if people have low mood, then again, you may get 2 benefits. And then PUVA stands for light therapy. So that can be, it's not really a long-term solution because you can't have light therapy for years, but courses of light therapy can be extremely effective. And this is some data. So Vinod Hegedü, who some of you may remember, worked in Newcastle a few years ago. So this was looking at how we do in terms of treating itch. And actually, the answer is, in some places, not terribly well, to be honest. So the bottom bar there is all comers with itch. And on the right-hand side, the bright red bar is people who are not on any treatment despite having itch. And unfortunately, that is over half of people with itch do not receive treatment for it. And I would very much say that's not acceptable. And I'd be very keen to treat itch as proactively as we can. And this is data taken from the UK PBC audit. This is now actually published. So people in the audience with PBC are probably part of UK PBC, so run out of Cambridge and Newcastle, and it's now nearly 9,000 patients across the country, which is a massive achievement. And this was looking to see how we do when we compare practice to what the guidelines say we should be doing. You can see that the second bar down there is the fact we use ursodeoxycholic acid. And actually, sadly, that is the only one of the markers of good practice where we hit target across the country. So we're pretty good at giving urso. But unfortunately, beyond that, things start to deteriorate. So symptoms, noticeably, only 60% of people are appropriately asked about their symptoms, or at least documentation is made of that. People with PBC are at increased risk of osteoporosis, so that needs to be screened for. And again, only about 50% of people have had appropriate assessment with a bone scan. And people with PBC who get cirrhosis need surveillance of that just in the same way as any other form of liver disease. And that usually involves an ultrasound scan every 6 months. And again, only about 70% of people were having appropriate testing. So I think this just emphasises that we do have quite a variation in care across the country. We have clear guidelines, we have clear targets, so we can benchmark, if you like, how well we're doing. And there are pockets of care that need to be improved. And recently we have developed what we call a PBC bundle. So that's essentially a kind of checklist, tick list to help doctors in clinic to follow kind of through what we should be doing step by step about the different aspects of PBC. And there's also a patient-friendly version of that bundle being developed. And this is, so we don't need to worry about the detail of this slide, but I think this is just trying to give a positive message, that actually the drug companies are increasingly interested in autoimmune liver disease and understanding the importance of autoimmune liver disease. In fairness, PBC has been part of trials for years, and again, many of you will have taken part in them. So this is just some of the medications that are under trial at the moment. Some of them are kind of newer versions of fibrates, essentially. And for example, seladelpar, the third one down there on the right, is quite a long way through assessments. And at the bottom, we've got kind of, if you like, souped up versions of ursodeoxycholic acid. Actually, Nor-Urso is being trialed in PSC as well. And these are medications that are being trialed in terms of blood tests, but actually, I think equally, and if in some ways, if not more encouragingly, there's also, for the first time really, an importance being placed on developing medications for symptoms. So we've said about itch, and we do have quite a lot of medications, but we equally do still transplant for itch. And the IBAT inhibitor type of drug, so those medications are quite a long way through trials, and there is some positive data. And fatigue and cognitive symptoms, we've mentioned, are really one of our greatest challenges. Fatigue, some of you will have been aware of the rituximab trial that we ran in Newcastle. So Laura Jopson, she was then Laura Griffiths, led that trial. So rituximab is a very, very powerful immune suppressant, and we trialed it in fatigue, and it didn't have any extra benefit over the placebo. But we now, for the first time, have a new trial, so golexanolone. So that's just going through very early phase testing. That's just happening in Nottingham. But we're soon going to open the second phase of testing, and that will be open in Newcastle as well. And we've also already mentioned obeticholic acid. So if we move on to primary sclerosing cholangitis, so PSC, so this is, in the majority of patients, a disease affecting actually the larger bile ducts draining the liver, in contrast to PBC, where it's the very small bile ducts. PSC is very rare, so it's only 7 per 100,000 in the population. And it can have various ways of presenting. Quite a large proportion, so 7 out of 10 people with PSC also have inflammatory bowel disease, so whether that's Crohn's disease or ulcerative colitis. And all patients at the time they are diagnosed with PSC should have a colonoscopy to look for inflammatory bowel disease. If you've got IBD already, then if you then get a diagnosis of PSC, that you should have a colonoscopy every year. And that is because, unfortunately, patients with colitis do have an increased risk of bowel cancer if they also have PSC. So we need to be really vigilant and look out for that. And although I've mentioned that PSC is rare, on the right here, there's recent work showing that the prevalence, so the number of people with PSC at any one time, is gradually increasing over the years. And you'll notice a common theme. So there's UK PBC, but there's also UK PSC, and they've also undertaken a national audit a couple of years ago looking at the management of PSC across the country. And again, unfortunately, demonstrating there is quite a lot of variation in the care people receive. I think one of the big changes recently, so we've talked quite a bit about ursodeoxycholic acid and PBC, and for a number of years, I've used it in my PSC patients, but without definite, we don't have good trial evidence. Interestingly, though, if you look at the UK PSC audit, about 50% of people in this country with PSC are being given urso. And there has recently been a change in the guidelines. So ASLD are the American guidelines and EASL are the European guidelines. And for the first time, there is now a formal recommendation we should use urso for patients with PSC. We are aware that there isn't evidence that, you know, in a proper placebo, so that's the dummy drug versus urso, there is not proper trial data. But actually, if you look at the big studies, for example, UK PSC, there does appear to be quite a clear improvement in blood tests, and this potentially maps on to improved long-term outcomes. And we don't have an alternative good treatment for PSC, so I would certainly take urso if I was a patient with PSC. We do increasingly have some trials coming through for PSC. So the NUC5 trial, which is running in Newcastle amongst many other centres. So this is the ursodeoxycholic acid that I mentioned earlier. Again, detoxifying bile acids. It's anti-fibrotic, so that means anti-scarring in the liver and trying to dampen down inflammation in the liver. And data here on the right, that's a graph from the kind of second phase trials showing that actually we definitely get a significant improvement in blood tests, again, the alkaline phosphatase. And the phase 3 trial is just completed, so we're hoping to get data out of that very soon and see if it's a positive drug that may move on to being licensed. And unfortunately, one of the things we know about PSC is there is a risk of cancer as complications of PSC, one of which is bile duct cancer. So cholangiocarcinoma is the term for that. And any of you who are under my care for PSC will know that you get quite a lot of scans. And it's quite difficult for us to know how we should look for bile duct cancer when there aren't good blood test markers, and it can be difficult to identify a complication. But actually, if we now have data again from both Europe and America suggesting that if we have patients on regular scans, that actually you have a better pickup rate of cancer, and actually that maps onto longer, better survival. So the guidelines would suggest at least imaging every year, whether that be an ultrasound and or potentially an MRI scan. The same for any other form of liver disease. If people are cirrhotic, they should have a 6-monthly ultrasound. And there is also an increased risk in gallbladder cancer. So in patients with PSC, if they have a polyp in their gallbladder, we would take the gallbladder out at a much earlier stage than in somebody who didn't have PSC. And quality of life, so I think in PBC, it's very well described and recognised the impact of the disease on quality of life. But I think it's been less well reported over the years in PSC. And PSC support, which some of you will be aware of, is another superb patient support group, and they recently did an international study in partnership with the European Reference Network, looking at patient-reported quality of life. And this is the results from the worldwide results. And interestingly, they found that nearly 90% of patients had some form of symptom. 3/4 of patients suffered with fatigue. And actually, nearly 60% of patients with PSC describe itch. And traditionally, itch hasn't been recognised as being such a problem in PSC. So this is something we really need to be turning our attention to. And thinking about the itch in a bit more detail. So actually, the bottom bar here is people, all comers who were receiving any treatment for itch. And actually, about 50% of people are receiving treatment for itch, which I think, to be honest, despite the fact the vast majority of my work is autoimmune liver disease, I'm surprised that the proportion of PSC patients with itch is as high as that. So that's a learning point for me as well. And then one of the really kind of things of high interest at the moment is PSC and the microbiome. So the microbiome is just a description of all the bacteria in your bowel, in your gut. And the gut and the liver have a lot of crosstalk and interaction. Bile acids from the liver circulate round and round and round in the bowel. And given the very strong relationship between PSC and inflammatory bowel disease, I think it makes sense to think that there must be some crosstalk. And there is some interest in whether changing bacteria in the bowel in some way triggers imbalance in the immune system. The microbiome is vastly complicated, and as you might expect, there's lots of things that kind of have an effect on it, going even right back to how you were born, your diet, bile acids, what infections you've had over the years, what antibiotics you've received, what medications, and even some data to suggest that mood impacts on the gut. And UK PSC, this slide is courtesy of Palak Trivedi. He's based in Birmingham and is driving a lot of this work. So there are a number of programs, studies looking at the microbiome. Again, the detail is less important in some ways, but just to demonstrate there's a huge amount going on. So vancomycin on the left here. So vancomycin is actually an antibiotic. And there is small data in pediatrics, so children with PSC, to suggest vancomycin might be beneficial. The middle, the yellow there, actually is fecal transplantation. So that is taking the stool from healthy people and giving it to people who have disease to see if changing the microbiome, changing the bacteria affects their disease. So I think this is a fast-moving area, and I think we're hopefully results certainly of the early trials will be coming through fairly quickly. And this again is a complicated slide, but the point to be made is actually PSC all of a sudden is really becoming of interest to drug companies. Again, this is Palak's slide, so I can't take any credit for this. But right on the left-hand side, so the orange areas are preclinical. So those are really early stage trials where people are just trying to identify compounds that might be beneficial. But we're moving through onto the right-hand side, the grey bit, and the right on the far right, the yellow bit. So these are medications that are now quite a long way through evaluation. The top bit, so volixibat, if you can see it. So volixibat, you might remember that you saw this earlier on the slide about PBC. So this is one of the IBAT inhibitors, and it's being trialled for itch, both in PBC and in PSC. Hopefully we'll see some good positive outcomes. And towards the bottom of that grey bar, second from bottom, is seladelpar. So again, we're seeing seladelpar being trialled in both diseases. And on the far right there, norazodioxycholic acid, the trial that we've mentioned that's hopefully going to be reporting. And I think we might get some kind of early outcome data presented at the European conference this year, which is in June. So I think this is really positive. PSC has been the kind of orphan disease in some ways in terms of not having much drug company involvement in comparison to PBC. So I think it's very positive that they're getting involved. And then moving on to autoimmune hepatitis. So this is the really the third of the major autoimmune liver diseases. And it sits in the middle. So it's rare, but it's in between the other two. So 17 per 100,000 people. And in contrast to PBC and PSC, which are bile duct problems, autoimmune hepatitis actually affects the cells in the liver and causes inflammation. We usually use steroids, specifically prednisolone, to get that inflammation under control, and then add in a second medication to keep things under control. And almost always I would use azathioprine. There are four kind of main aims of treatment, broadly speaking. We want to get good control, and we call that biochemical remission. And we really use blood tests, generally speaking. So we talked about alkaline phosphatase in the other diseases. Here we're talking about ALT, not ALP. So that's a marker of inflammation. And we also monitor a blood test called IgG. So this is, again, a protein produced by the immune system, which, if it's high, can suggest autoimmune hepatitis. Ultimately, we're trying to aim for people to be on azathioprine on its own. So we want to try and get everybody off steroids. And we want to stop disease progression. We want to make people have better long-term outcomes and avoid transplantation. And in parallel to that, we want to improve quality of life. And again, a common theme you can see on the bottom right here, we have the UKAIH logo. So I run UKAIH, and again, anyone in the audience who's got autoimmune hepatitis may well be partaking in it. And a massive thanks actually to Liver North, because they fund UKAIH and have done for the last, certainly the last number of years, and are extremely supportive in allowing us to continue running the study. And there are a few questions. I mean, autoimmune hepatitis, well, there are lots of questions, but we're gradually trying to work our way through them in the research community. Now, steroids, anyone who's taken prednisolone knows that there are pros and cons. It's a very good drug at getting on top of inflammation, but it likewise comes with lots of side effects. And this data published in Europe. So the Europe groups often use very high doses of prednisolone, and actually we've demonstrated we don't need to do that. So 0.5 milligram per kilogram per day. So for example, if you're 80 kilograms, we would give you 40 milligrams of prednisolone, and that dose is just as good as giving you 100 milligrams. So we get good treatment response, but with less side effects. So I think that's a really important point for us as doctors when we're prescribing. And again, one of the commonest questions probably I get asked is about budesonide. So some of you, so prednisolone is the kind of common steroid, if you like, and budesonide is it's different because it gets processed only in the liver. You can't use it in patients with cirrhosis because of that. But there is a lot of interest in when and in whom we should be using budesonide. And this largely came about because there was a study over a decade ago now published by Michael Manns, who works in Germany, suggesting that budesonide was better than prednisolone, both in terms of people's response from their blood tests and also in terms of having less side effects. The kind of not alarm, but our kind of concern was that actually it also showed that prednisolone didn't work very well, which I have to confess is not what we see in clinical practice. The vast majority of people actually have a very good response to prednisolone in terms of their blood tests. This left us in a position where we weren't quite sure where budesonide sits in how we manage autoimmune hepatitis. Now, this is a rubbish slide because I copied and pasted the graph, and I need to get a better copy of it. But this is very recent data just published at the back end of last year, suggesting that actually if somebody has a new diagnosis of autoimmune hepatitis that is very active, then actually prednisolone is the drug we should be going for in terms of steroid. That doesn't mean that budesonide shouldn't be used. Budesonide, I think, undoubtedly does have its place, but I think generally I tend to use it for people who need a little bit of steroid longer term, who get lots of side effects of prednisolone. So I think it does have its place, but I would be cautious about using it to gain control of autoimmune hepatitis. And I've talked about this concept of biochemical remission, so this ALT and IgG. And we know increasingly, this is, again, relatively recent data, normal blood tests do matter. The top bar here, the solid black bar, is people who have normal markers of inflammation in their liver. And actually, they do better longer term in terms of avoiding the need for transplantation than people who have abnormal blood tests. So that should undoubtedly be our goal of treatment. And FibroScan, any of you who come to liver clinic, either in Newcastle or increasingly elsewhere, will probably have had a FibroScan. So it's a bit like an ultrasound scan, and it puts sound waves into the liver and measures the stiffness of the liver. And we're increasingly understanding that this is can be used as a helpful marker of remission, good treatment of disease. So we can use that in combination with your blood tests and your FibroScan. And this helps us avoid needing to repeat liver biopsy, which obviously is an invasive test. And I think the reverse is true. Potentially, if your FibroScan is on the rise, that may be suggesting that your disease is becoming more active. So I think this is increasingly helpful information. And I think this is really important information. I think particularly people who are diagnosed, so new diagnosis of any diseases can be very overwhelming. And if you're told you have cirrhosis, that is extremely scary, all the things that people hear and see about cirrhosis. But actually, cirrhosis is not a one-way street. So in autoimmune hepatitis, good treatment can reverse the amount of scarring. So we can go from having cirrhosis at the time of diagnosis, and actually years down the line, the cirrhosis kind of effectively have gone away. So that isn't true for everybody, but I would say that actually it's not a one-way street. And a very positive message I would give to people when I meet them is that the amount of scarring in your liver will probably improve over the years as we give you treatment. And one of the other questions I get asked a lot is, can I stop my treatment? And the answer is, well, maybe. Traditionally, actually, the data would suggest that people who stop treatment have a really high risk of relapse. And that's about 80 or 90% by the time they've been off treatment for up to 3 years. And I think that, so it's a discussion to be had, and it's really important that we discuss it regularly, I think, at clinic appointments. But I think increasingly we probably need to be a bit cleverer about it. There are potentially a small group of people who can come off treatment. We may be understanding a bit better. So people who have absolutely kind of supranormal, so not just borderline normal, but very low results for their IgG and ALT, may be able to stop treatment. But you should have had complete disease control for at least a couple of years, and you shouldn't keep going around the cycle. So if you have a relapse after relapse after relapse, that is a predictor of developing cirrhosis. And just a last note, I just thought this paper was quite interesting, and I'm actually looking at, as part of the UK AIH work, I am just doing a study looking at vitamin D. But it's interesting that, as many of you will know from COVID and all sorts of things, vitamin D is one of the things that's being kind of bandied about as a very important. And this study from a few years ago suggested that being severely vitamin D deficient did have a negative impact on survival for patients with autoimmune hepatitis. As I say, we are just processing quite a lot of data on the UK AIH patients, so hopefully we'll be able to publish that in due course. And my apologies, it's a slightly whistle-stop to it through the 3 diseases, but I'm more than happy to try and answer any questions.
Wow, Jess, there's some data in there.
I know, sorry. I don't know if it's too much.
Absolutely fantastic. And that'll help a lot of people because it's going to be available on our YouTube channel. You know, it is a whistle stop tour, but people can scroll through and pick up with the bits they want. You know, so that's great. I've got a couple of questions before I hand over to everybody else, if you don't mind. It's really interesting that you're hardly biopsying anyone now. That's really interesting. I mean, we've still got it in our leaflet of tests that you may need a biopsy. So I suppose it's still essential for some things, but
Yeah.
you know, that's an interesting thing. The URSO side, you had where people who didn't give the right dose did worse than the people who were given exactly the correct dose for their body weight.
Yeah.
That was your slide showed people who got too much or so, and people who got the right dose.
So greater than 13 is the top bar, I think, on that slide. So yeah,
Yes.
so in PBC, there isn't so much data to suggest too much is dangerous. The target would be 13 to 15 milligrams per kilogram, and anything less than that is not enough.
Okay.
In PSC, actually, very high doses shouldn't be used. I didn't go into that in that much detail. But yes, the message very much in PBC is that you need a proper dose in order to get the full beneficial effect. And actually licensing for obeticholic acid demands that you have had to be on that dose. So if you come to me and you've not been on a proper dose, I can't give obeticholic acid because you've not had proper treatment with Urzo.
Blimey. That's interesting. But do you think that the other hepatologists all understand exactly across the country that this has got to be done exactly right?
I think that message is getting out more and more. I suppose one of the issues is, of course, people put on weight, so it's just for us to be thinking about, actually, when we see you, are you still on the right dose? And conversely, some people lose weight. The number of people. So, I mean, obeticholic acid is a new drug relatively. We've got a big nationally, if you compare us to the other, we've got a big cohort of people on obeticholic acid. The number of people who've come through on a low dose it's small numbers, but it does happen. But I think that message is getting out there more and more.
Excellent. And the last thing I want to say was that the spring liver news is coming out. I've already mentioned, but we have details of the Oaks trials and how to join them in it with the advert. So if anybody wants to get the liver news, they just email us and we'll put you on the mailing list. It's free, but it has details of all trials that are coming up. And also Jess has a little page or two updating you on things. So that's excellent. Now, any questions, anyone? You can raise your hand like that, or you can use the inbuilt hand signal thing that's in Zoom. Well, that's a good sign, Jess, isn't it?
Well, either that or everyone's kind of stunned into silence in a bad way. Who knows which?
Well, there was a few thousand words in there, so that's brilliant.
I know. Sorry, I did. I should
Oh,
have
that's
said
good.
update in one disease rather than all three. I went a bit broad, I
No,
think.
no, it's really good because it becomes a resource for us, and it's on our YouTube channel that people can look at and fast forward, stop, turn, go back. That's really good. It's a bit like having a DVD. Yvonne, you've got your hand up. You'll have to unmute.
Thanks, John. Thanks, Jess. Thanks ever so much for that. Obviously, I'm not a patient who suffers with any of the autoimmune liver diseases. But however, there was something you said about a bundle that obviously the and I think the bundle was referring to helping the clinicians as opposed to helping the patients. I'm just wondering if there's anything that you could see that might help, whether it be PBC, whether it be PSC, or whether it be AIH, that would help as a Liver North leaflet. I don't know.
So the bundle, yeah, so there's various bundles. So we developed them for all sorts of things. So we started with the decompensated cirrhosis bundle, and it's kind of evolved more recently. The PBC one's the most recent. There is going to be a patient-friendly version of that that will be freely accessible. There are also kind of the traffic light cards and things for people with PBC to understand their alkaline phosphatase. And of course, Liver North have, I don't know, John, 28 leaflets now. I don't know, I lose count.
Yeah,
There's
that's
loads
it.
and loads of them, aren't there?
Yep.
The one, I mean, I wrote the one on PSC, and I think we did talk about kind of potentially updating some of the others. I've just finished off one trying about understanding your kind of tests and things. So hopefully those provide a bit of information, but they could certainly be revamped. I think the PSC, the PBC, well, even the PSC ones, though, all three of those are quite old now, probably, aren't they?
The clinicians are so busy to do it. We've asked, people to review them, and it is going ahead, but it's very slow.
I could do PSC and AIH again, or PBC as well.
All right, right, that's it. You've got those three. I'll get in touch with you by email. What did you say again? PBC, AIH?
I'll do all three. I can do all three if you want. That's fine. Yeah.
Brilliant. Thank you.
Sorry, Jess, I didn't mean to sort of add to your workload there. Sorry about that. It was just that it was when you said it was for the clinicians. I just wondered if there was anything that could be specifically for the patient side of things. But I think obviously what you're saying is I think the updating is going to cover that side of it.
So the traffic light, so for PBC, because there's very much targets for PBC and this idea of risk and response and incomplete response, and some of the people on the call I recognise. So UK PBC, their website has it, but it's also available in a paper format. So there is a traffic light thing, so you can map your own blood tests and see where you sit in terms of a risk profile. So I think some people quite like that because it gives them they can monitor themselves and also understand where they're sitting in terms of risk. So that's one of the kind of patient tools, if you like, rather than doctory tools.
Thanks, Jess. Sorry again to add to your workload. Sorry.
It doesn't take me. It's all right. I don't mind doing them because I write stuff about these diseases all the time, so it's fine.
That's excellent. You're probably aware that the British Liver Trust have been touring the country with the FibroScan, and they seem to when it's a score of 8 or more, they tell people to go and see a doctor. I mean, we always tell people to see a hepatologist, and I've got, it's not because we haven't got any faith in gastroenterologists or GPs. We just think it cuts the journey shorter if you see a hepatologist straight away. But are you getting referrals from people who've had a FibroScan outside of the NHS?
So not so much. So there's lots of interest going on in terms of early detection, though. So nationally and locally. So the early detection of cirrhosis pilot is happening, and that happens all over the place. And I think they're doing it in kind of places like Nissan, for example. They're going and doing kind of drives in big, and I think also at the what do you call it? The
DHS.
Yes, but
the ministry.
The ministry around the back of the Freeman. Yeah. That's all about identifying people at an earlier stage of liver disease. So Stuart McPherson is kind of has helped drive that forwards, and I think Aaron Wetton, who's our kind of most recent addition to the liver team. So there's the early detection pilot. There's also SOLID, which is Stuart McPherson's primary care, so that's based in primary care, so in GP land rather than in hospitals. So that's trying to identify people with liver disease and equally identify people who don't have liver disease, if you see what I mean. So trying to streamline referrals and avoid people, ending up presenting very late, so that we can try and intervene earlier. So there's lots of work, and there's various programs around the country using slight kind of variations on a theme, but yes, and Love Your Liver road shows the kind of thing you're talking about. People literally drive around the country in a van and park up in Morrison's car park and do FibroScans on lots of people.
That's right. I wonder if they find out if anybody's pregnant by doing that. But never mind. It's the same kind of thing. The other thing I was going to ask you is, have you had anything to do with the Great North Care Alliance that's coming along? I don't know if you heard about it, but it's Newcastle, Gateshead, Northumbria and Cumberland sharing resources. And I know you're operating at Sunderland now. You work at Sunderland some of the time. And I know that there's quite a few services provided by Newcastle to Cumbria now.
So it's I think it's kind of a work in progress, isn't it? So in terms of liver, we're trying to provide outreach, and again, some people on the call may be aware of this, that so as you say, I run the outreach service in Sunderland, so I just do one clinic there on a Tuesday, but dedicated to liver. Steve Masson goes to Middlesbrough, Dr. Jopson, Laura Jopson, Nay Griffiths goes to Stockton, Dr. Patel goes to Durham. So we're trying to make it so you don't have to live in Newcastle to access, you know, kind of tertiary liver. And Carlisle, so there is a bit of it, there's a developing link with Carlisle. The links with Carlisle are more developed in other areas at the moment. But yes, I mean, it will come in due course. And of course, Gateshead and Newcastle becoming more closely aligned.
Yeah,
we don't have an outreach service in Gateshead, but they have Dina Mansour's there, who's, you know, liver specialist. So they have a kind of good basis there as well. I think that will come. I think more and more there's a ever increasing network, and actually the doctors at the various different hospitals, you know, the Sunderland guys, for example, we all have you know, there's lots of cross-talk and referrals backwards and forwards. I think it works quite nicely.
Yeah, well, it's good. It's just because our helpline will tell people to ask for a hepatologist. You know, you've got patient choice now. When you get secondary, you refer this, and you know, people should go and see a hepatologist. That's our advice, because they'll end up seeing a hepatologist who have a liver disease anyway. But that's it from my questions. Anyone have anything else? No. Well, thank you so much, Jess. It's been really enlightening. It's really useful to get an update on everything that's going on. And I'm sure there'll be a lot of people. Yes, there's applause coming from a lot of people who are very, very grateful.
Hi, Team Bennett.
Thank you very much. Yeah, well, Alf does the review of this talk, and he'll be putting it in the next Liver News.
And I can see Jane's message. Hello, Jane. Long time no see. I hear you're doing very well. Good to see you. Well, can't see you because you haven't got your camera on, but
no, Jane had difficulty joining us, but she's there now anyway.
I can maybe say hello now. Yeah.
Oh, good. Hello, Jane.
Well, thank you.
Yeah.
And I was that person who woke up with no itch, like you said.
I saw you were on the call, but I didn't say that. But yes, yeah.
So
it's
how
like
long
winning
since
the lottery, but better.
How long since your transplant, Jane?
Be 10 weeks on Saturday.
Fantastic. Fantastic. Okay, folks. Well, thank you so much for attending, and we look forward to seeing you at the next meeting. Okay. Bye.
Thank you very much, guys. Lovely to see you all. Take care.
Bye.